Aloha and welcome.
Speak to the microphone.
Aloha and welcome. May I call the meeting of the dual use of cannabis task force meeting to order?
And we just have a housekeeping matter. In-person task force members, please make sure the sound on both your device and the Zoom platform are muted at all times. If you wish to speak, please raise your hand and a wireless microphone will be brought to you.
To establish quorum, I'm going to ask each of the task force members to please state your name and the organization that you're representing. So I'll start with members in the room. Ms. Calvin.
Department of Business, Economic Development and Tourism.
It's optional. Randy.
Randy Gantz, representing the industry, the director of the Hawaii Cannabis Industry Association.
Jared Regola, the Narcotics Enforcement Division.
I'm Michelle Nakata. I'm with the Office of Medical Cannabis Control and Regulation at the Hawaii Department of Health. Now, if we could move to the online members.
Harold Otani, Hawaii County Mayor Mitchell, Executive Assistant.
Nikos Leverance, Hawaii Health and Harm Reduction Center.
Garrett Hollander, academic researcher.
Terry, go ahead.
Terry Lynn Gorman, Office of the Maui County Mayor.
I'm Wendy Gibson Viviani. I'm a medical cannabis nurse educator and a patient advocate.
Jackie Rothas, I'm the office manager for Senator Sam Buenaventura, who will be joining later.
Garrett, I'm sorry, did I miss you earlier? Garrett Halliday.
No, I'm Garrett, academic researcher.
Thank you. And Nikos, did we get you earlier? I'm sorry. Okay. Let the record show that we have one. Thank you.
We're now going to move to consideration of approval of meeting minutes for April 25, 2022. We'll take testimony on that agenda item, starting with those in person and those on Zoom and then those on the phone. Please note at this time, we're only taking testimony on agenda item number 2. Is there anyone here in person who wishes to testify on that agenda item? And I'm gonna hold on until we do the public part, and then we'll come back to that.
I would like to speak about the minutes.
Yeah.
If nobody else is. I'm not.
Hold on one second.
Okay.
So let the record reflect there are no in-person people who wish to testify. So we will now move to Zoom testifiers. If there's anyone on Zoom that would like to provide oral testimony in agenda item 1, or agenda item 2, I'm sorry, please raise your hand. You'll be invited to join as a panelist. When I call your name, please unmute yourself. If you feel comfortable, please turn your camera on if it's not currently on. And I'm waiting for names that will be brought to me in just a minute, please. So thanks for your patience. Thank you. So Clifton Oto. Mr. Oto, are you prepared to submit testimony on this item? I don't see Mr. Oto there. Am I missing? There he is. Mr. Oto, if you have testimony on agenda item 2, this would be the time to present it.
Yes, can you hear me?
Yes, we can.
Great. Well, good morning, Chair, Vice Chair, members of the task force. My name is Dr. Clifton Otto. I believe you have my written testimony before you. Just wanted to briefly comment on agenda item 2. I was looking at the list of members from the minutes, and I would suggest that if possible, to add an email contact for the members in case the general public had any questions for members, along with a list of any associations with any dispensaries, either here or on the mainland. And in the minutes, there's also discussion of adding a certifying physician and certifying APRN to the task force. And I was asked who I thought would be good members for that. And I just wanted to add that maybe one way to think about that is a certifying physician and certifying APRN who are currently certifying patients and who use this as their primary healthcare service.
Okay,
So
Mr. Oto,
those are my comments.
Okay, I just want to remind you and the others that want to testify, right now we're focusing just on the approval of the meeting minutes.
Yep.
Mr. James Anthony, are you ready, sir?
Hi there. I'm just concerned procedurally, sir, with the, Your Honor, with the minutes process. I realize it is difficult to take content minutes as opposed to mere action minutes. And so I appreciate that the task force is attempting to capture some of the content of the comments made by the public and by the task force members. But because that is necessarily going to be incomplete, I'm hoping that these recordings that are being made, that we have all consented to, right, as part of participating in this Zoom meeting, will continue to be provided as a reference. I don't think that the state of Hawaii is so short on electrons that we cannot continue to occupy some space on YouTube to maintain this for, what I think I have said before is really a historical time in ending the war on drugs. And so I'm hoping that you will maintain the YouTube recordings, and I appreciate your taking the time now to review the minutes and ensure their accuracy. Thank you very much.
Great, thank you, Mr. Anthony. And the last person through Zoom is Dale Rosenfeld. Mr. Rosenfeld, your testimony on item 2, which is the approval of the meeting minutes.
I have no comment on approving the minutes since I cannot see them, nor can I see the agenda when I click through online. If there's an easier way for me to see them someplace, I would comment. Otherwise,
All right.
I'll hold until this is done.
Thank you. If anyone who called into the meeting by phone would like to testify on agenda item 2, please press *9 to raise your hand. When prompted, please press *6 to unmute yourself. Do we have anyone who wishes to testify on agenda item 2 by phone? Like no one at this time? No one at this time, all right. Madam Chair, I'll turn it over back to you for consideration and approval of the meeting minutes.
I think there were task force members that had comments regarding the
Yes, and
minutes.
I know you want to say something about the meeting minutes.
Thank you, Chair. Specifically to item 2, welcome address. I was trying to reconcile the statement, explore development of tools, system program deliveries on cannabis with the legislation itself. I am unsure what that exactly means. The specific term that I'm confused with is on page 3 of the bill, but the specific phrase is on qualifying patients. So are we here to legalize marijuana and the impacts of legalization on qualifying patients? And the term qualifying patients is used twice in the legislation. So what exactly are we here to do?
It's my understanding that the legislation is to convene a task force to consider the possibility of legalization of adult use, or what's termed more generally as recreational use of cannabis, or use by an individual who is an adult. And should Hawaii decide to legalize adult use, what would be the potential impacts on the current medical use system and the access to cannabis for medical use by patients? By qualifying patients, meaning the patients that are currently registered for medical use.
So the report is basically what would legalization of cannabis be on qualifying patients, not on the general public, not on law enforcement, not on anything, but on qualifying patients.
Yes.
Am I reading this correctly?
I think it's both. It's to consider more generally.
Okay, so where do you get that generalization in the bill?
Actually, it's not specified.
Okay, so that's fine with me. It's not specified. So basically, Chair, should we just ignore the term qualifying patients and just say general public, so we kind of know its impacts on everybody in the state of Hawaii? Or do we go with the legislation and just go on qualifying patients? I don't know. Whatever direction you guys want to take, just give me clarification.
I think the concern is just we want to ensure that if Hawaii were to move forward with adult use legalization, are there potential impacts that might
be beyond qualifying patients? Although the legislation says qualifying patients, we should establish at this particular time, the purpose of the task force will be expanded to make sure that it's for everybody, from law enforcement to Department of Taxation to general public to qualifying patients to everybody. Is that correct?
Correct. That's
okay. So if that can be reflected in the minutes, I would appreciate that, and we can put that in your interpretation too in the minutes. That'll be fine with me. I just need clarification.
So we're expanding it beyond qualifying patients. I thought that was what the law says our task is, to look at qualifying patients, the impact on the current program.
If I may.
So Act 9 does say explore the development of a dual system program of legalization of cannabis.
Okay.
And dual system does mean adult recreational use in addition to patient medical use. So it does encompass both forms of use.
Okay.
Conjunction and Tuesday.
Any other comments by the task force before you vote on whether to approve the meeting minutes?
Yes, I actually object to approval of the minutes in their current form if they are to replace the video or it's not an accurate reflection of the testimony. I appreciate the efforts to condense the testimonies down into bullet points to make it easy for us to understand. But I feel like not only did a lot of information get missed, but some of it was not entirely accurate. And I went through the videos twice, transcribing and editing the notes. And I'd like you to take a look at that and maybe, before we approve the minutes to include some of the important, well, what I consider to be important information that got left out. So it's not entirely accurate or complete, and I'm not in favor of just approving the minutes as they are.
Any other comments by the task force?
I would like to second Ms. Ms. Viviani's comments there, and I think it's critically important that this task force maintain a video record that's accessible to the public on YouTube. It's important for not just our purposes, but also for the general public, particularly advocates and interests on our neighbor islands. And to the extent that we can have and maintain these deliberations on YouTube, I think it would be beneficial for the process and for the legislative process as well. Mahalo.
Any other task force members who wish to speak to the issue of approval of the meeting minutes? Please.
Yes, hi, I have one minor correction on page 6. Second bullet. It starts with Organic Costa. My name is spelled wrong. It's Story Topic, which is C, not a K.
Thank you for that correction.
And I have one more
Of course.
minor question. On page 3, at the very end, the second to the bottom bullet, it says events. And I was questioning that first sentence, and it could just be I'm not reading it correctly, but it says a number of members less than a quorum may attend informational events that are related to the task force's business, but may not or hurry a vote. So is it saying but may not attend informational events, or is it before something else? I'm not sure. Clarify that.
Madam Chair, do you wish to speak to that? Were you following where she was?
I'm not clear, I'm sorry, I'm not clear what the question is.
Okay. In the events bullet,
Yes, I'm here.
the second sentence, related to the task force's business, but may not or hurry a vote. I'm not sure what that means. I don't know if the or is correct in there or not, so I just want to minor, but
I think the or is a typographical error,
okay,
and it should just read may not hurry vote.
okay.
Any other task force comments before? Yes.
Chair, is it permissible to dispense with writing minutes and just using the recording from now? So we never have this debate again and just use the recording as our minutes?
Yes, it's acceptable. We can do that.
Require a motion for that?
Yes, we will.
I'd like to make a motion that we dispense with the written minutes of the meeting and just go with the recording. Further, I think the recording should be kept by the chair and available to the public on public platform.
I didn't hear what the proposal was.
The proposal is that we provide the copy of the meeting recording in lieu of written minutes.
To ensure that nothing is left out.
Okay.
Is there a second to that motion? There's a second. I'm sure you want to take a vote on that?
Okay. All members in favor, please.
Point of order, Chair.
I'm sorry, go ahead.
My issue with using the recording is a lot of the audio is not clear. Like right before this, someone was speaking. I think it was a task member, and I could barely understand what they were saying. So you can put the recording on, however, it's not very clear.
would it be helpful if I submit the transcription that I've done so far? I've got like 6 pages of transcription, and so they can, condense it or edit it down, and maybe we can vote on this at the next meeting or something, like on the revised minutes or something.
And then the Deputy Attorney General is now consulting with the chair.
The Zoom also provides for transcription. So you can do a Zoom transcription. However, I can tell you that the Zoom transcription, the quality of it is not that great. And so I don't have a problem with using the audio the virtual recording as the official minutes. However, I would prefer to have summary minutes. So I think one of the issues has been, like, for instance, the way the testimony was reflected. If you do summary minutes, you can do a bare bone minute and just have the recording. I'm hoping that you can use the recording for all testimonies. So that would minimize any quote unquote inaccuracies or misrepresentations regarding what the testimonies are in the minutes.
So Deputy Attorney General, there's a motion on the floor. It's been seconded for the virtual recordings. Now we have a proposed change to have virtual recordings plus summary minutes. What's the best way to present it to the task force?
Well, I mean, it sounds like some motions. So
Yeah.
I will either amend the motion, just change the motion. Proceed with the vote.
Yeah, are you, Ms. Chi, you proposing we amend the motion to have virtual recording and summary minutes?
If the maker of the motion will accept the amendment and the seconder of the motion will accept the amendment, I believe then you can go forward.
All right.
Yeah, I made a motion to substitute the written minutes for a video recording. I do not accept your amendment. I feel that the recording is that's exactly what it is. If you do have a hard time hearing the motion, it'll be even harder to look at the video and try to make minutes from it. So that's nonsensical. So I'll stand by my motion to substitute the written minutes for an audio version, which I think will be the most accurate. Thank you, Chair.
So, Mr. Deputy Attorney General, I assume we need to put that to a vote, a motion to a vote. All right, Madam Chair.
Okay, all those in support of the current motion, please indicate by raising your hand.
I'm sorry. Senator Sam Buenaventura is here. So if you guys could make her a panelist.
Thank you. We'll hold for until we can get.
So you see the hands up again. In our room, we have 5 hands out of 5. All right. How many hands do we have on Zoom?
May I ask for clarification, please?
Sure.
Oh, okay.
Could somebody read the final statement of the motion? Is it to replace written minutes with the recorded minutes? And for council, is this legal?
First of all, your understanding of the motion is right, is to replace the minutes with virtual recording. And I'll ask, the question was, is it legal to replace the written minutes with the recording? And the answer is yes.
Yes.
So we're just waiting now. Madam Chair is conferring with the Deputy Attorney General.
If I could make a comment. This is Joanne Mishita Takeichi from DCCA. I suggest, can I suggest that this issue be deferred until SB 3172, which is currently under consideration, that would revise the protocol for keeping transcripts of minutes and recordings. Until that bill is resolved, because it will be germane to the vote that we're taking right now. Thank you.
Thank you. So the proposal was to defer the matter until there's a decision made on SB 3172, which apparently would be determinative of this issue. So I guess that would require withdrawal of the motion. Mr. Choi? Are you prepared to withdraw your motion or you want to proceed?
Let's proceed with the vote.
Okay.
Okay. So all those that I call, okay, again, so the motion currently is to request that the recording of the meeting be used as the official minutes of the meeting and to be posted publicly and maintained. All those in favor, please, if you're on Zoom, raise your hands, as well as those in the room.
How many do you count, Madam Chair?
2, 3, 6, 7.
And how many people are present in the meeting?
Finish counting.
13 are
We have
present.
13.
So I believe the motion passes, correct?
Correct.
Motion passes. Thank you. All right, we're going to move to item number 3, panel presentation and discussion on issues states face when transitioning from a medical cannabis only program to a medical and adult use. And again, we're first going to take testimony from the public, and we'll now take testimony on that agenda item. Please note at this time, we're only taking testimony on agenda item 3. And I'm going to remind our testifiers that you have 2 minutes to provide testimony on each agenda item before it's addressed by the task force. I'll give you a 30-second warning, and we'll call time in 2 minutes. This is to ensure that each person wishing to give testimony has an equal opportunity to speak while allowing adequate time for the task force to work through the agenda. If you're in person who wishes to testify on agenda item 3. Are these in person or these are Zoom? Zoom. All right, so it looks like there's no one in person, so we'll move to Zoom. And I have here the first name looks like Kyle Vare, Mr. Vare. I see you there, Mr. Vare. Are you prepared to testify? Yep, your hand's up and it's your turn. You ready to proceed? If you're talking, you're on mute. Mr. Vare, I'm just going to wait a couple more sentences and then we're going to have a couple more seconds. We have to move on. I see you there. We're going to give you an opportunity.
Can you hear me?
Yes, we can. Please proceed.
So sorry about that. First of all, I'd like to say thank you guys so much for, allowing Michelle folks at the Department of Health working so hard and getting this this together. I think moving forward, this is going to be more or less, this is crucial for the success of this program or these programs. I just wanted to say that, if we really look at what we have a medical marijuana system in place, but really, being born and raised in the state of Hawaii, having the privilege of working in each county, not for the county, but each county, living for a while, really, marijuana it's been a big part of our culture. It's been there. So now we got to figure out, how to make this, it's here already. So having us talk about it and realize it's coming now, I think this is the key to our success. And I'm on Hawaii Island, so including us away from Honolulu, the outer islands involved in this conversation, because I know going forward, what works for Honolulu may not work for the rest of us. So we appreciate so much you folks having us put in input. How do we pay for our programs? Because of course it's going to need to be regulated. Having our input, we greatly appreciate having us involved in the conversation. So I just like to say thank you so much for allowing us to speak and allowing us to be in on this conversation.
Thank you, Mr. Bears. Mr. Clifton Odo. Mr. Odo, please proceed.
Yes, thank you, Chair. I just wanted to comment on agenda item 3 that I'm hoping that, can you hear me?
Yep.
I just wanted to comment that I'm hoping that your panel presenters will touch on how they had to deal with the violation of federal drug law when they were initiating their adult use programs. Thank you very much.
Thank you, Mr. Odo. Mr. James Anthony, are you prepared to proceed?
Yeah, I apologize, Your Honor. I'm a little disorganized. I'm trying to find the agenda. Remind me, please, what is item 3?
So the task force is about to hear from a panel on issues that states face when transitioning from a medical cannabis only program to a medical adult use, and we're only taking testimony now on that subject.
Yeah. So my suggestion to the task force, Your Honor, having worked in a drug policy and it's specifically in regulated medical and adult use cannabis policy in California and other states in the United States for the last 17 years, is to take all of this testimony with a grain of salt, which these presentations by these people from other states. Every single one of them has been an unmitigated disaster. California has a rampant underground cannabis market, which is as big as ever, out of control because of overregulation and overtaxation. Similar problems exist in every other state in the United States. And finally, none of their social equity programs, because they were added as afterthoughts to disastrous, unworkable programs as sort of window dressing, it is ridiculous to attempt to address the issues of the harm of the war on drugs through an overregulated system. And that is what every single one of these other states will be talking to you about. Hawaii can, will, and should do much better. Thank you very much.
I'm going to ask you to conclude, please, in 30 seconds. Thank you.
Oh, thank you. So my suggestion then is that given the benefit of the experience of 10 years of overregulation in legalized states such as Colorado and Washington, and the disastrous social equity programs, the state of Hawaii can and will and should do much, much better. And thank you all for taking us down that path.
Thank you, Mr. Anthony. We're now ready to hear from any phone testifiers.
We have one more Zoom.
We have another Zoom, okay. You could just give me that person's name and we'll hear from them. So actually, it looks like we have 2 more. All right. Dale Rosenfeld. Mr. Rosenfeld, anything you wish to say on agenda item 3? It must be limited to agenda item 3. Please proceed. Do we see Mr. Rosenfeld? I see Mr. Rosenfeld. It looks like, is that Mr. or Mrs. Dale?
Aloha, Ms.
Aloha. Thank you. Please proceed.
This is Dale Rosenfeld on Kauai. There we go. I'm on Kauai, and yes, outer islands are a totally different animal, plant than Honolulu. I hope that as these panelists speak and we hear their different stories, we understand that every place is unique And within Hawaii, the islands, each of them are unique. I hope that we also have a chance to testify after we hear them speak, and that it's put together in a cohesive manner for people to really understand what those differences are. Mahalo.
Thank you, Ms. Dorsey. The last person through Zoom is Margaret. I'm sorry, that was Ms. Rosenfeld. Thank you, Ms. Rosenfeld. Last person is Margaret Dorsey. Ms. Dorsey.
Aloha, chair members. I just want to say that when we listen to these presentations from people from other states who have transitioned from medical to recreational, I just want to really focus on and hear about what happened to patients when these states did switch and there was no medicine available for them. What was put into action, or is there any way to ensure that when it does switch, that there is a way for patients to still access their medicine who were in the original medical program? Because I know, as we all have probably seen, a lot of them, when these states went legal, there were lines out the door, the dispensaries sold out, et cetera, et cetera. So I just want to hear about that. And yes, thank you.
Thank you, Ms. Dorsey. Are there any phone testifiers? Called in on phone, you're aware of? No, we have no phone testifiers. So Madam Chair, I'll turn it back over to you for the panel presentation.
Thank you, Jeff. So next we have a recorded panel presentation from 5 states, including Colorado, Michigan, Nevada, Oregon, and Washington State. I just wanted to make, they will, in the recording, they will introduce themselves and their titles, but I wanted to just call out that there is a correction to the information that's on the agenda. The Nevada representative is Mr. Steve Gilbert, who is the Chief of Administration for the Nevada Cannabis Compliance Board. And for Oregon, the Jason Hansen was not able to participate. So the presenter is the other person who's listed, who is Amanda Bora.
Madam Chair, just one question, and then I want to mention something to the task force. Can you tell the task force how long the panel, how long it is, just so they have a sense of it?
I think the entire recording ran just under an hour.
Okay, I just wanted them to have a sense of that. And then task force members, when the panel is done and you're done listening to them, we're going to ask what questions you have for the panel. The Department of Health is then going to collect those questions, send them to the panelists. They're going to respond back with answers, and those answers will be distributed to you. So be thinking about that as you hear the panel. Okay?
All righty, so good afternoon, everyone, and thank you all for joining us for this session that will be played for the Hawaii Dual Use of Cannabis Task Force. And just for introductions, we have joining us regulators from 5 other states, and I'll go ahead and introduce each of you in alphabetical order by your state, and if you could just say a little bit more about yourself and your role with your state's program. So first off, from Colorado, we have Dominique Mendiola, who is the Senior Director of the Colorado Marijuana Enforcement Division at the Colorado Department of Revenue.
Hello, Michelle. Thank you for the opportunity to speak with you today. Again, my name is Dominique Mendiola. And I serve as the Senior Director for the Marijuana Enforcement Division. I joined the MED in 2014 and previously served as the Deputy Director for the MED and have grown in my role over time. I'm happy to talk more about the agency if helpful, but understanding we're going through introductions initially, we'll pause right there.
Okay, great, thank you. So next up, we have a state of Michigan and Mr. Andrew Brisboe, who is the Executive Director of the Michigan Cannabis Regulatory Agency. Andrew?
Thank you, Michelle. Pleasure to be here as well.
As you said, I'm the executive director of the Cannabis Regulatory Agency. I'm on my fourth title now, but have essentially been in this role since 2017 when commercial legalization came to Michigan. And I am responsible for the agency that oversees our patient and caregiver registry program, as well as our licensing and regulatory programs for both the medical and adult use markets here in the state of Michigan.
Great, thank you, Andrew. Okay, so next up from the state of Nevada, we have Mr. Steve Gilbert, who, and I apologize, Steve, I do not have your current role with state of Nevada, so you're going to have to provide that for us.
Thank you, Michelle, and it is an honor to be here and speaking with everybody. So Steve Gilbert, I'm the Chief of Administration for the State of Nevada Cannabis Compliance Board. I started with the medical marijuana program back in 2014 when it was at the Division of Public and Behavioral Health under Health and Human Services in Nevada. In 2017, the program then transferred to the Department of Taxation, where it was housed for about 2 years. And now finally, we've landed with the Cannabis Compliance Board, which started in 2020. And again, I'm the Chief of Administration overseeing licensing and registration.
Great, thank you, Steve. Next up from Oregon, we have Amanda Borup. And Amanda is the policy analyst for the Oregon Liquor and Cannabis Commission.
Thanks for having me, Michelle. Yes, I'm a policy analyst with the OLCC, and we actually are the agency in charge of the adult use system in Oregon. The medical system in Oregon is still through the Oregon Health Authority. And I was hired at the OLCC right after our ballot measure passed legalizing adult use in November of 2014.
Thank you, Amanda. And last but not least is Justin Nordhorn from state of Washington. He's the Director of Policy and External Affairs at the Washington State Liquor and Cannabis Board.
Well, hello, everyone. Thanks for having us on. Happy to engage in this manner. So my name is Justin Nordhorn. I'm the Director of Policy and External Affairs for the Washington State Liquor and Cannabis Board, and I've been with the organization for just about 24 years. I have been in this particular role for about 18 months, and prior to that, I was the enforcement chief and had most of my career in the enforcement division. We have a system where you have medical cannabis integrated into our adult use. Our Department of Health still does the regulatory and policy oversight over medical, and we do policy oversight over the adult use or recreational. And my role is helping with legislation as well as rule development for the organization. Thank you.
Great. So thank you, Justin. So just to kind of give a little bit of a background, the dual use of cannabis task force was required of the state health department as a part of legislation that was passed in 2021. And basically it requires the health department to convene a task force to consider a dual use system. In other words, implementing adult use legalization for cannabis on top of our current medical use system, and also to specifically address any potential impacts on the medical use system and especially on patients and their access to products for medical use. So all of your states have successfully made the transition from medical use to adult use, and you've been up and running for a bit now. And so I guess one of the first things that we would be really interested in knowing is some advice for you. What was your experience? What was, I guess, some major unforeseen obstacles or issues that arose as you began your transition from adult use to medical use? I mean, I'm sorry, from medical use to adult use. And I guess shall we start with, I guess, Washington and Colorado? I think you guys were the first two up.
Sure, I guess I can jump in from Washington because we have a little bit different system on the medical side. So just as a brief history, in 1998, our legislature passed a bill basically legalizing medical cannabis, and yet there were some implications to state employees on managing some of the systems, and the governor at the time decided to veto sections of that particular bill, which left the medical cannabis market, if you will, unregulated. So there was no licenses required, and that stayed into effect until after legalization occurred for adult use in Washington. So in 2011, the initiative I-502 passed, where we implemented the recreational use within the state. And there was still a side industry, if you will, that was not mandated to be licensed, that was in the medical field. And so 2015, we consolidated both of those particular areas together. So the medical use program got folded into the recreational use program. And we have Department of Health again is overseeing the medical registry database, the provider type of details, some of the training that goes to the bud tenders and consultants. And we handle basically the points of sales, youth access, tax collection, all of those types of fundamentals. And as we transition, I think one of the real challenges for us is having an unregulated system for a very long time. And then there was no mandate to come into the system initially for the adult use side of things. And so we had two competing markets. One was highly regulated, the other one wasn't. And then when they collapsed the two together, we lost a lot of outlets, if you will, that were predominantly focused on cannabis patients and access. And so in our state, when that transition happened, the operations of the dispensaries that were providing product for patients changed dramatically. And there was a lot of expectations in our state that with our Senate Bill 5052, it was in 2015, that there would be better access for patients because they could get it in any store and those types of things. And what we learned from that is actually it was far less expensive to produce the adult recreational use because our medical program with Department of Health had higher testing standards for pesticides, heavy metal, and other safety dynamics. And so the licensed producers didn't produce all that much medically compliant product. And so that was kind of a pitfall of one of our systems. And as it's developed, I talk to a lot of patients now because we're trying to get a handle on and fix the system because the collapse of the two together did not meet the patient expectations. Our registry is, we didn't have one previously, and in 2015 it came in. And then there was an estimated from the patient community, they would estimate about 150,000 patients. I think on a per capita average, if I look at a bunch of states together, we probably would have about 85,000 patients, and there was only 20,000 that actually registered. And there's a significant portion that has not renewed. There's a lot of distrust of a registry in our state, and so that's been problematic. And there's no incentive for patients really to get into the system because we only offer a sales tax exemption for the patients, and then they also get a higher possession limit, but they still have to pay a 37% excise tax on their medicine, which is a real challenge for those folks. So I'll stop there and let somebody else jump in.
Thanks. I can just jump right in if that's all right. And just an introductory statement on our agency so that folks understand the scope of our role at the Colorado Marijuana Enforcement Division. We are housed within the Department of Revenue in Colorado, and our responsibility is to license and regulate the commercial, medical, and adult use markets in Colorado. And so we license owners, employees, and businesses. They're all required to be to submit applications and gain approval before they operate as a marijuana business. The Department of Health in our state oversees the medical registry, And this is one of those examples where it's really important for us to be coordinating very closely with our partner agencies in our state, all who have very important distinct roles in cannabis regulation or oversight. We oversee approximately 3,000 businesses across the state, and that involves around 40,000 individuals who are licensed to own or work in a marijuana business. And for some additional background on our history of our transition from medical to adult use, our transition was through a constitutional ballot initiative. In November of 2000, Colorado became one of the first states to legalize medical marijuana, and that was through what is known as Amendment 20. And then in 2010, we became one of the very first states to establish a regulatory framework for the cultivation, manufacture, and sale of medical marijuana. This is where we came in and we're known as the Medical Marijuana Enforcement Division. Then in 2012, Amendment 64 hit the Colorado ballot, and that touches on adult use. And that passed in November of 2012, allowing businesses to operate, as well as personal use possession allowances. We had a period of time to establish a regulatory framework there. And when it comes to challenges that we faced, something I wanted to flag is one of the more recent initiatives that we've seen here in the state from recent legislation is tied to the availability of inventory for medical marijuana. And in the previous legislative session, or the one before, we just concluded our legislative session this year, but in the prior year, we saw an initiative to address availability of medical inventory. And as a result of that, we implemented a new law that allows, under certain circumstances, for businesses to change designation of marijuana from adult use or retail, as we refer to it here in Colorado, to medical. So there are now allowances for that, or this coming month there will be. And we also just this year saw an effort to allow for a change in designation in the opposite direction. So we will be working to implement that as well. So that touches on just availability of inventory, which is important to be monitoring. So just wanted to flag that as one of the more recent developments that we've seen. Some other just general developments and challenges that we have faced, and this is more general as we've seen and implemented a more expanded model from and framework from medical to adult use is, related to things like edibles and things, issues that we encountered, including when we initially rolled out our adult use framework. We began to see issues around how edibles were being manufactured, and some edibles being indistinguishable from regular food products you would see at a grocery store. And so this did prompt some efforts on our part to ensure cannabis products could be more easily identified. And so that also included looking at how we are ensuring that labeling is in the right place when you have layers of packaging, that the child resistant requirements that are in place here were also applied to the appropriate layer of packaging when you started seeing development of products with multiple layers of packaging, where maybe the outermost layer had all the labeling on it, or the child resistant component to it, which is also the layer that was most likely to be discarded. So we did have to address that, as well as serving size limits that apply to adult use that do not apply to medical products. That was an initiative and stakeholder engagement that we rolled out, and also looked at how we were needing to see products marked to ensure that they were easily separated and could be identified based on their serving size requirements. Other initiatives that I can just touch on very briefly are, as we've seen the market expand, we've seen new products in the market, some more medical device in nature seeming. So we've had to ensure that we're keeping pace and have the regulatory authority to conduct rulemaking as we need to, without having to go to the legislature every year to ensure that we can address the range of new products that we're seeing in the market. Licensing requirements is another area that I would flag as a challenge that we navigated, transitioning from medical to adult use. We initially had a framework for licensing where every owner, no matter the percentage, had to go through an application and approval process. Over time, that has resulted in changes as well as allowances for additional and expanded investment opportunities like publicly traded company investment. And so we've just had to keep pace with that. And that has resulted in some exemptions from disclosure application requirements to make sure that we're able to process applications and focus in where we really need to, which is on those businesses that ultimately have control of the business. And that's either actual control, day-to-day operational control, or through a percentage threshold, like 10% or more interest in a business would trigger that application and approval requirement. And I'll pause right there as well.
Great, thanks, Dominique. Amanda, I think Oregon was probably the next in time order.
Okay. And I can definitely give a little bit of a history as well as especially the medical marijuana in Oregon. So our medical marijuana program started in 1998 in Oregon, and it was very loosely regulated. There was really even no regulations around dispensaries until I believe 2014 or maybe 2013. So it was largely unregulated for about 20 years prior to adult use, the ballot measure passing. One of the big things that happened here was our ballot measure actually said that the adult use system would not do anything to harm the medical system. With that being said, as more legislation was passed, something called early start happened, where the legislators said they wanted medical marijuana dispensaries to be able to sell to adults 21 and over while the adult use system was set up. So all of the dispensaries in Oregon basically were able to sell to anybody, not just medical card holders anymore. And one of the things that we saw happening was when we started to actually license retail establishments, most of those dispensaries just switched over and became adult use because they could still sell to patients, but then they could also have a huge other part of the market, which was anybody 21 and over. Another interesting thing in Oregon is that since the medical was very unregulated, there were really no testing regulations. There were no packaging and labeling regulations. I mean, it was kind of a little bit of a free-for-all. And so when adult use came on, all of those things became requirements. So somebody that was processing, let's say, tinctures for a patient prior to testing wouldn't have had to do any testing on it. They could just make it and give it to the patient. With the new regulations, that would require testing. And so that adds an extra expense on the production level, and they aren't able to give things as freely to patients as they used to be able to. That being said, Oregon does have the same thing with Washington, similar, where medical card holders do not have to pay the sales tax in Oregon. And since we don't have a sales tax generally in Oregon, they don't pay the tax. So they do get that benefit when they're shopping in the stores, and they can buy some what we call medical grade products, which are specialty products that only card holders would be able to buy. But just to kind of give you an example of how the market has changed, I looked up the numbers today, and in April of 2016, so that would have been right before, well, we started licensing retailers, I believe, in the end of 2016. So this would have been the very end of that early start portion I was talking about. We had over 70,000 patients and over 40,000 growers, because in Oregon, each patient could designate a grower or grow for themselves. Today, or in April of 2022, we have 20,000 patients and just almost 7,000 growers. So we've seen a dramatic drop in the medical marijuana program itself. And we currently only have one dispensary in the state of Oregon that's medical only. So I think that some people haven't been renewing their cards because unless you get a reduced rate, you could spend about $200 a year to get a medical card here. And so people really were looking at like how much they would save in tax. You know, if they don't buy very much, then they probably wouldn't need to get a card because it's not going to be that different as far as the price they're paying. Other people still were using like large amounts of marijuana and wanted that tax exemption. And so they were able to continue using their card, or they still have the grower relationship that they had before. That's also very possible. Technically, we don't have any licensed medical processors in Oregon. So those growers would just be giving the patient flower material. And so we think that that could be why, you know, a lot of the registry card holders have dropped down because people are just buying it through the licensed retail stores. So that's kind of what we've been seeing here in Oregon.
Thank you. Yeah, it's interesting, especially when you you mentioned, you know, the dates for implementation of the various aspects of your program, because people are often surprised to find that Hawaii was actually not that far behind Oregon. I think our medical use program was just 2 years behind Oregon, though it was legalized through legislation and not through you know, any kind of a ballot measure. And I think and our dispensary system is actually only a year or two behind Oregon as well. However, since then, you know, Hawaii's progress has pretty much you know, stayed where it was and not advanced like Oregon's has. But I would say, you know, in a lot of respects, Hawaii and Oregon both have a substantial of what would be considered a legacy market that, you know, was in place before legalization efforts began, you know, and has, at least in Hawaii, has still remained fairly strong.
I would agree with that. And I think in Oregon, one of the things that was really different here, when we had our adult use start, we had very low barriers to entry. So basically the goal here was to get anybody into the legal adult use system who wanted to come in. Our application fee was $250. Our highest license fee was just under $6,000. So it really was a movement from the legislation to really be able to move people who may have been semi-illegal or completely legal, but move them into the adult use system if they wanted to come in.
All righty, Steve.
All right, so Nevada, the patient registry was passed in 1999. So it kicked off very slow traction. It wasn't getting much traction. I think they're through up to about 2013. There was only 2,000 patients that were registered in Nevada. In the 2013 legislative session in Nevada, medical marijuana establishments was passed, which legalized establishments to sell cannabis or marijuana to patients. So in 2014, the medical marijuana program kicked off at the Division of Public and Behavioral Health and our Health and Human Services. Patient registry, you know, grew quite a bit. I think we peaked at about 28,000 patients in Nevada. For 2 years under the medical marijuana program, we were able to really build a good foundation of what we wanted to look for as far as packaging and labeling. We solidified all of our testing requirements in those 2 years, not knowing that recreational or adult use would be passed shortly after that. But we were able to take those 2 years and build a really good foundation with, you know, it wasn't very busy. They were slowly coming on board. We licensed them in 2014. I think the first one opened up maybe in mid 2015. And then slowly after that, so we were able to learn along with the industry on what they needed and what we needed to really lay a good foundation for the program. Then we also had a ballot question, and in 2017 is when adult use was passed, or July 1st of 2017 was the legalization date. What we did is we took the medical marijuana license holders, and we also had a quick start, early start one for one, we name it a few different things, where we're able to take the medical marijuana license holders that were in good standing and allow them to apply for a one for one adult use license, which allowed Nevada to kick off the adult use program right at July 1st of 2017 and start, allow sales to start on July 1st, which worked out very well. Some of the challenges that we had was of, managing the seed to sale systems and transitioning from a seed to sale system that was being used at Health and Human Services to a new seed to sale system that the Department of Taxation, who now oversaw the Marijuana Enforcement Division, wanted to implement. And we went with Metric in 2017, 2018 timeframe, and integrating that with an established industry under medical and then a new industry under recreational or adult use, created some challenges. Nothing that we didn't work through. We're very happy with the CSL system right now that we're using. And that was one challenge. And also administratively, trying to change agencies in the middle of a transition always created difficulties in licensing, different licensing processes. And then also something that Amanda, I think it was Dominique that mentioned, now that we're the CCB, so we oversee and regulate the medical marijuana industry as well as the adult use, all under the Cannabis Compliance Board. Taxes and collection of taxes stayed with the Department of Taxation, which helps our oversight of the regulatory process. So we don't have to deal with the taxes. And also the patient registry stayed at the Division of Public and Behavioral Health. So health registers patients. The CCB oversees the regulations of the industry, and taxes remained at the Department of Taxation. And one thing that we saw early on with the Cannabis Compliance Board was the need for more in-depth suitability checks on licensees. So we've hired an investigations chief who came from our state gaming control board, and he oversees an investigation division which does extensive suitability checks on all of our licensees, whether that's new licensing, any transfers of interest, and any change in officers or board members. They go through a suitability check, which has allowed us to really look into who's doing the daily operations of the business, what percentage do they own, and is able to have us know a little bit more of what's going on in our state as well as other states also. Another thing that we had to define when we transitioned from medical only to medical and adult use was defining the inventory and how the inventory was going to go through the supply chain. We allow retailers to designate whether it's medical or adult use at the point of sale, unless they designate the medical marijuana from the very beginning. So if they tag it under Metric as a medical marijuana product, it needs to remain through the whole supply chain as a medical marijuana product. But if it is recreational and a patient does come in and presents their patient registry card, they do get a 10% discount, and the point of sale or the clerk can designate that as a medical marijuana program or product at the point of sale, which has allowed the cultivators and the producers to not have to manage two different inventories without knowing, how much medical marijuana they're going to sell. Right now, medical marijuana sales represents about 78% of the sales, which is a drastic decline from what we saw in 2014, 15, and 16. I'll stop there. I got more for the other questions, so I'll let somebody else go.
Okay, great. So Andrew, I think Michigan is probably one of the newer states that has become adult use, and so interested in hearing how the benefit of having watched several other states make that transition first, and what kinds of issues you saw, and hopefully Hawaii's hoping to learn from all of you as well?
Sure. So Michigan had medical legalization in 2008, but no commercial program until 2016. And so we had quite a large, like many of my predecessors spoke about, this unregulated marketplace that established itself over 8 years, where we had 300,000 or so registered patients, 45,000 caregivers who were growing on behalf of them, and had very liberal allowances as well, up to 12 plants per patient being grown. So we had really a quasi-commercial system in place that was completely unregulated. But we dealt with a lot of the transitions of replacing that supply chain with this new commercial system in the implementation of our medical market in 2016 till 2018, when adult use legalization came online. So we had worked through some of those challenges already. And I think we really tried to focus on learning from other states to establish consistent standards in the commercial market, which was a little bit simpler with one coming after the other. And because we have a single agency that's responsible for developing those standards. So that allowed us to have some fluidity between the markets as well, allowing some of those market to market transfers so the products could get in the place where the consumers needed them or wanted them, so that we could head off some of the sort of inevitable illicit market impacts where there will be supply to meet the demand one way or another. I think some of the challenges that maybe we didn't predict all that easily were some of the local political issues. In Michigan, local units of government get to determine what types of businesses and how many can be there. And with medical legalization already being in place and businesses being established, and the voter initiative that legalized adult use in 2018 passing with such a good margin, it was sort of surprising how many communities were loath to allow the adult use facilities. And that led to a little bit of a lack of access, particularly on the retail side, but also a lot of lawsuits where it can now be safely assumed, I think, in every state that businesses that get into the medical market do so with the intention of broadening into the adult use market. And if they are not provided that opportunity, or they're passed over, where we saw some communities that had, say, allowed 15 or 20 medical provisioning centers, basing those numbers probably not on real good science, but just on sort of the political wherewithal to do so, wanted fewer adult use retailers. That those businesses that were not afforded that opportunity were certainly going to challenge those decisions in court. I think we also saw a more intensified focus on THC. Once we saw adult use legalization, we have what I would call a fairly naive consumer market, where that's the only number they know to look at to judge the quality of the product being made available. And so that is going to cause producers in their interest to make profits through rapidly declining prices with the increase in supply, to focus their energy on that and turn their energy away from producing those products that are more typically used by medical consumers, because they're just going to be producing high THC flower and making vapes and concentrates, and not so much focus on some of the one-to-one products or some of those other types of products that are more necessary for medical consumers. And then the other challenge that I think we were sort of on the cusp of with legalization that all the other states are facing now was the concept of social equity, and the fact that that concept didn't exist in medical commercialization, which gave all of these businesses a head start with higher barriers to entry. And then we were in a position to try and quickly sort of backtrack and focus our energy on how we benefited those communities most impacted by the war on drugs, and had a need to focus on diversity and equity and inclusion and ownership of businesses in this space, but had sort of been dealt a challenging hand, considering we now had this robust infrastructure in place, a lot of investment in the state in this free market system, and our ballot initiative that legalized even gave a further head start to those medical facilities, because they were given priority for licensing for a couple of years. So I say that to say that any state that goes into this adult use market or a recreational market will face all of those same challenges every other state has faced before you, but there will be novel issues that you'll be working on at the same time that all the states are now facing as being new issues as well.
Great. So thank you. My next question is really to think back on your experience, and if you could offer Hawaii recommendations, say your top 3 recommendations or areas of focus that looking back on your experience, you would have prioritized for your state, what would they be?
I can jump right in if that's all right, Michelle.
Yeah.
So initial thought, and I touched on some of the new products, a range of new products we've seen, and in light of Amanda made some statements around just the availability of certain products or limited participation, at some point or currently that she's seen. One of the areas that we have seen and had looked to our counterparts in other states that we're very appreciative of is how we're keeping pace with what's in the market and what are we doing in our regs on that front. And we had, in our coordination with our partners in other states, had developed an intended use model in our regulations that helped us better define the scope of allowed products in the market. And I think when it comes to any interest in identifying certain products that perhaps should only be available in the medical market, while that does not apply here in Colorado, I appreciate what was shared here and how there may be an interest in that. And when it comes to other regulatory frameworks, where having an intended use model or some framework that allows the regulatory agency to have a line of sight to what's out there, it could be very helpful in how we're tracking inventory or determining whether certain limitations should be in place for the availability of certain types of products. And so from that, we had established certain categories of product types that are permitted, and anything beyond that would not be allowed outside of express approval, either through an approval process that we've built directly into our regulations or through a statutory or regulatory change. And so we did create categories from inhaled product, oral consumption, skin and body products, and then audited products, which is an area that we've seen or heard about an interest in certain types of products like a metered dose nasal spray or products that are intended for other purposes. We also have a category that we refer to as alternative use product that we had defined as having higher risks, public health risks associated with them. So with that comes more scrutiny and approval requirements. So we did build that into our regs in recent years. We also, when it comes to priorities to consider, is ensuring you have sufficient rule-making authority. And I mentioned this earlier. So ideally, you're not having to go to the legislature every year. And that's where you're looking at what is that, mandatory rulemaking, but also what is permissive? Where can you have that more general rulemaking authority that allows that regulatory agency the flexibility that's going to be really critical at certain junctures. And this is examples include the EVALI related issues that were experienced that allowed us, and because we had our general rulemaking authority around the manufacturing of certain products or ingredients that could be used, that allowed us to act very quickly in response to what we were seeing. Similarly with COVID, because of our general rulemaking authority that we already had built into statute, we were able to respond very quickly to ensure that that businesses were able to operate in a manner that they were able to keep themselves, their employees, and customers safe through social distancing or other measures like curbside drive-up services or walk-up services. So that's something that I would suggest you take into account. Thinking ahead when considering how you staff your regulatory agency, I think is really critical. We initially established our agency with very much a focus on licensing functions and law enforcement functions. We have since evolved and we have scientists, we have data analysts, financial examiners with a lot of experience in both private and publicly traded company transactions. And so that's been very valuable to us, but it was something that we have done in more recent years. That diverse stakeholder engagement is really critical. It's just a final point, and agency engagement is a staple to lean on the subject matter expertise that is in the industry and the community has been really critical to our success and the work that we do. engaging with your local partners. In Colorado, we have a dual, a dual licensing system where anytime we are approving a license, it still requires local jurisdiction approval, and then coordination among our partner agencies. Like other states, and I had mentioned our public health agency oversees the medical registry program. We work closely with the Department of Public Safety on law enforcement related matters, issues like large home grows and the ability to ensure that we can support those investigations or verify whether somebody is licensed or not, or serving as a caregiver or not. The Department of Agriculture has a role as well when it comes to scales and weights, and hemp is another area where we have some crossover. So that centralized point and engagement, and for us, it's through the governor's office, has been really critical to ensuring that we're staying on top of things.
Thank you.
I want to jump in so I don't always have to go last. Plus, I'll be quick because Dominique stole all the things I was going to say. So I guess I will just underscore what she said. The two I had that she almost said verbatim were flexibility in policy and robust stakeholder engagements with all constituencies, because this is a new and nuanced and challenging area. So you really have to engage with all those folks to understand their needs. And the one area, and I think our state did those things relatively well. The one thing that we didn't do, and I'm not sure any state has done it as effectively as they would have liked, is do more data gathering before you legalize. I think we were all forced to be very reactive to the fact that it happened, and then to figure it out as we were doing an implementation, which often was, at least in my state, was we had a year for both medical commercialization and adult use to stand up the program and do everything, including staffing and policy and IT systems. And there wasn't a lot of time then for gathering information. And then as a follow-up, you're expected to have the data on what some of the impacts have been, but you don't have the baseline data to compare it to. And I think we all would say we want to use data to inform policy making, but I don't think we've been afforded that opportunity. So hopefully this exercise is providing Hawaii with an opportunity to do that piece of it.
And I was going to say pretty much the same thing. Dominique had a lot of my points that I had written down here that were very important. The only other thing that we've heard in Oregon that's a little bit different, and maybe other states have heard it as well, is that patients do feel like a little bit left behind when adult use came on. And in Oregon, what they've done, the legislative bodies have set up ways where product can get to the retail level and be given to patients for free, because like I said, they don't have to pay the sales tax. A normal 21 and over consumer could not get anything for free. But we haven't really seen a lot of acceptance of that through our licensees. And the OLCC, where I work, we're fee funded based on our licensing fees. And so we're not really able to give any like monetary, like encourage people to do it with money. Basically, we can't really do that. And so I think if there's any way, and maybe it doesn't have to be money, but any way that the adult use licensees can be encouraged to consider patients, in when they're making and how they're selling it and their pricing. I think that's something that if we can figure that out in Oregon, we're going to make a lot of people happy, because they really do feel like they're kind of an afterthought at this point in time, even though they started, this whole kind of cannabis revolution back in the 90s, right? So that's the only thing I would add.
I don't have a whole lot more to add. I mean, I think we all have the same suggestions. I think echo the staffing. It's very important to have a very balanced staffing model. Unlike Dominique, we were heavy in the inspection and the audit side, and probably low on the investigation and enforcement side. And we learned that going on as we went. It's great to have a lot of inspectors to start, but then you're still waiting for the establishments to open up to go in and inspect. So balancing that staffing model will be very important, making sure that you have the right balance of investigation versus inspection, licensing, administration, just because it all has to work together to make the whole thing work well. And then also on the regulations. So at our Health and Human Services, the regulation process or rulemaking process was very extensive and long. Took a long time to change the regs, even if it was a minor housekeeping rule. And we've now gone to more of an expedited rulemaking regulation process to where our board, which is a 5-member board, can approve or adopt regulations, which has made it much easier for us to react to industry needs, as well as internal needs also, when we find that the regulations need to be tweaked or changed a little bit to help us or help the industry. That's really all I have to add on those.
All right, I guess I can jump in. So in Washington, I would also echo a number of the things, although we kind of shifted from a different role. So, but the staffing issues and all those types of things highlighted, I won't recover. I think one of the things that, looking back, the way that we implemented the issues, there's a lot of assumptions made based on what the program would do for patients. So I guess I would start off by saying, if you coming from a medical infrastructure and you're going to open it to adult use, you're opening it up to a considerable amount of consumers, which means that the demand for the adult use products may drive the interest of the retailers. So the medical product may actually get on a back burner. So I know in our state, we had different standards of safety on medically compliant product versus general use product. And so since it was more expensive, the licensees, we couldn't force them to bring in medically compliant products. So I think we still only have about 2 producers really focusing on medically compliant product. And so there's an assumption that there are many patients who utilize the recreational system, so therefore their medical needs are being met. And other patient groups, encourage us to challenge that assumption because there's still a number of illicit market activity going on in our state, meaning farmers markets and those types of things, because the patient interests, I don't think, were captured in our transition as well as they could have been. When we look at, or at least from what I've heard from patients, they want to know their grower so they can trust that grower. So it doesn't really matter what the test results mean. They really rely on that ability to understand what their growers do. They want to have the product that they believe that they need, not what the state is kind of putting into the box. And how product is being sold. When we transition into the recreational, everything has to be packaged. Patients had a long-standing expectation and practice of being able to go into a dispensary, see the product, smell the product, and now you have a sniff jar at best in our state. So the form for getting your product is definitely different than what it was, and I'm not sure that all the considerations were met, and it kind of goes to what Amanda was saying, that the patients kind of feel left behind. They had high expectations, and nothing has really come forward to meeting those. On a kind of a different area, with the increased volume of potential clients coming into the stores to purchase product, you may end up having other issues around banking, more predominantly. Cash-based businesses, we're seeing, currently increased numbers of robberies that are going because, and we have a fairly decent banking opportunity within our state because of the state union or credit unions and state chartered banks, but we're still having those acts of violence occur in our retail locations. And so, when you're doing that transition, if that safety concern is there for patients because they're more vulnerable, they may gravitate outside of those stores if they're not safe enough to go into, as well as just kind of food for thought there. And then in our state laws, we have some home growing provisions, and I know a lot of patients like to grow their own so they can control their product and control the volume. We have a limited amount of growing that a patient can do. And the more I talk to patients, I think we need to change that. And that's just my personal opinion, not necessarily that of the board. But when you're looking at the growth cycle of a plant and you're looking at how much product a patient needs for their medication, you're not going to harvest everything all at once. And so you're going to have a perpetual growing cycle. And so you're only going to have a limited number of plants ready to harvest, which may not meet the needs of the patient as far as the quantity of product on hand. And the other thing is, if you limit the plant count, you also limit opportunities for doing small scale grows. So if somebody's in a wheelchair, for example, and they want to do a tabletop grow, they may have twice as many plants that are allowable, but they're half the size. And so those types of things, I don't think our state really looked at. And so I guess my whole point is, I would recommend, and looking back, I wish we had looked a bit more at the patient interest and needs, and not assume everything is going to work out, because I think that is creating more issues now as we try to correct it than we could have on the front end by addressing those and maintaining those interest points as it moved through.
Wow, great. I'm so appreciative of everybody's input. I would definitely say I agree with, having the flexibility in statutory authority to implement regulations. We currently have interim rulemaking authority, and fortunately our statutes for the most part are drafted fairly broadly, with language like the Department of Health shall establish standards with regards to laboratory testing requirements, which is wonderful because it basically allows us to to set those requirements and modify them as we learn more about what types of products are being produced and what the concerns and risks are for specific types of products. With regards to staffing up, I can fully appreciate that, having spent pretty much the past 2.5 years running the whole dispensary side of the operation with just myself and 2 inspectors, which has been pretty challenging, I would say. And then, finally, the comments about collecting data now is also something that we are definitely, now that we're starting to get some staff in place. We just got an epidemiologist position, so very much excited about connecting that person with as many data sources as possible to start collecting that information now, so that we can actually intelligently report about what happens or during our transition. We just have a few more minutes left, and I basically just want to close with a question, on what have you seen happen to your medical market, your patients, since the adult transition?
I can start. We've seen a drastic drop in patient registry. For example, when I think I used the number earlier, about 28,000 was our peak here in Nevada for patient registries. Then in 2017, when adult use was legalized, that started declining, I think 4 or 5% each month, to where the first year of adult use, patient registry declined, I think 40 to 50%. And that's where it remains now. I think there's about 13,000, 12,000 patients total in the state. So it definitely affected it. Early on when adult use was passed or implemented, we did hear a lot from the patients on product selections, and that we don't hear much anymore, not from the patient community as much as we used to. So I don't know if that means that they're happy with the products that are out there, or if they've just settled to go use the recreational or the adult use path. The products in Nevada, there are potency limits on adult use products, whereas medical products, there are not potency limits. So the cultivators and producers that choose to supply medical grade products can offer higher level potency on their products, which gives patients the option to either purchase adult use, and it'll cost them 10% more because they're paying the sales tax, or purchase the medical grade products at a higher potency.
Thank you.
I can jump in next here. And what Steve just covered had me thinking about some other things and current developments as well, but I'll just start off with, what we've seen is the number of registered patients, registered medical marijuana patients has steadily declined since our inception of the adult use market in 2014. However, in April of 2020, we did see the number of patients begin an upward trend. And so increasing from 80,257 to 85,814, coinciding with the onset of the pandemic. And a couple of reasons why we are looking at that and think that that may be the case is an increase in adult use prices could have made the lower medical prices more appealing if somebody was eligible to have a medical card. Also, we, during the pandemic, did have an executive order that temporarily allowed for telemedicine appointments. So that did provide some ease of access for those who have an interest in and were eligible to have a medical marijuana registry card. And then COVID-19 restrictions that we saw lead to an increase in customer purchases. So likely sensitivity to prices associated with that. And then on average, our data shows that retail, our adult use market makes up for 80% of the overall marijuana sales, while medical is 20. But another thing that we have navigated recently from this past legislative session is implementing new requirements and restrictions that applied only to the medical market and specifically concentrate. So similar to what Steve touched on, we before this had those limits tied to adult use products like serving size limits that did not apply to medical products. However, from this recent legislation, concentrate is now subject to a limitation, but this is something that patients felt very strongly about, is where could there be possible exemptions under appropriate circumstances. And so the law did account for that and provided us with authority to define exemptions. And so what we focused in on, and this is tied to either physical or geographic based exemptions. So what we were looking at is where could there be travel restrictions based on somebody's diagnosis or mobility related issues. So distance, geographic related distance restrictions, or based on somebody's, their medical marijuana recommendation and their physician, in consultation with their physician, a determination that they should have an exemption. So that's where it's been very important for us to make sure that we're providing information and working with both the public health department, but also what's been new for us is more interface with the medical community, and particularly physicians, recommending physicians or medical providers who are looking for guidance on how they could apply certain exemptions.
Leave time out.
Ready, can we proceed?
Yes.
Our tech folks, we okay? Okay, so just a quick announcement for the task force members that are in the room. When you speak, if you could please speak into the mic so the Zoom audience can hear you, okay? They raised that request. Just another reminder, today the task force is going to continue until you no longer have a quorum. I unfortunately need to leave at 2 o'clock. As you know, this meeting was rescheduled, and this was the best I could do, was to stay until 2. So I apologize for that. Future meetings, I'll be able to stay as long as you have a quorum. Let me tell you real quickly about the rest of the meeting. So we're going to solicit now questions from you about what the panel, what you just heard from the panel. Then we're going to take public testimony on agenda item 4. Then Chair Nakata will lead a discussion on agenda item 4, which deals with permitted interaction groups. And then Chair Nakata is going to request that you defer agenda item 5 because of time constraints, okay? So let's move right into questions that you would like the Department of Health to pose to the panel based on what you just heard. Task force members. Please.
My question is, I heard a lot about the importance of having agencies work together, and some of them saying that it was easier once they folded it together. Some different agencies coming under one. Would it be any recommendations to start off with one agency that oversees all of the programs, has that authority, so they don't have to liaison between 3 different departments? That said, I did hear from California previously last year that was a recommendation from their department, that they said that through their woes that they suggest that having one agency oversee the entire program, have the ability to make rules, come up with those fast decisions. So hearing from each individual to see kind of their input on that would be really important, given that now we have Department of Health, but we have others involved in the adult use program.
Would it be feasible to have one agency oversee everything? Okay.
And would that be a standalone agency within a department as well?
All right. Standalone within a department. Other questions, task force members?
Thank you, Chair. I'd like to know what the total cost is for the programs. I'd like to be informed of what the indirect costs are and direct costs are. Not interested in the social costs or anything like that, just pure numbers. Also what the revenue figures are. If there are any reports out there I could access for this information, that'd be fine. Also, if the compliance departments for these particular panel members could share with me any kind of compliance work programs, or audit work programs, that'd be great. Thank you.
Okay, so I got total cost, including indirect costs, revenue figures, and then what was the last one? Compliance?
Any compliance work programs.
Compliance work programs.
Yeah,
Got it.
if I could get that particular information, I can do my own costing on how much it will cost me.
Understand. Other task force questions? Hold just one second. Make sure that nobody else has one here live. And then I want to get our Zoom and then we'll come back. Anyone else here who's present? Okay. Any members of the task force who are on Zoom who have questions that you would like posed to the panel? Yeah.
Yes.
That you'd like posed to the panel?
I have a question.
Yes, please.
Oh, okay, okay. So Dominique, I believe it was, talked about the compilation of the regulatory group and how at first that they only included law enforcement and others, but then they expanded it to include scientists and others. And I was wondering how big of a group this became, because there are so many stakeholders. You know, how can we keep it a manageable number of people who are a part of this? Oh, you know,
How big the group was and how was it manageable at particular size?
Sure.
Other questions for folks, task force members that are participating through Zoom?
Aloha. My question, it might not be answerable, but I would like to ask the group to provide input on ways that, you know, Hawaii could facilitate the access to, you know, medical cannabis for patients who might not be able to afford retail prices. Is there a way that we could, you know, set up a structure where we would incentivize dispensaries or growers or somebody to provide, you know, quality tested product to people in need for no cost? And, you know, let's think about tax implications as well. And how can we make that work? Because one of the more remarkable things that I encountered when I experienced the medical cannabis landscape in California in the early aughts, back when people were getting raided, is that if you didn't have money and if you were in need, they would provide, you know, a flower or even edibles to people in need. and there was a barter system or something, and I'm not saying we need to do that, but the heart of medical cannabis is compassion and allowing people to access needed medication. Mahalo.
So the thrust of the question is seeking input from the panel on how Hawaii could facilitate access to medical cannabis for those who can't afford retail prices.
Correct.
Other questions by task force members who are participating by Zoom, those who have not yet asked a question.
This is Hawaii County. Just again, reiterating, seeking data, or since it's being pioneered from Seattle and whatnot in the Vision Zero initiative, just trying to make the correlation with this and with traffic fatalities, if there's any increases directly related to this here and how it's impacting their Vision Zero policy there and whatnot.
Okay, so data regarding traffic fatalities.
Yes.
Okay. Other folks who are participating by Zoom who have not yet asked a question, task force members, please.
Yeah, representing Mayor Victorino, County of Maui. I would like to ask the presenters, they all seem to indicate that when they implemented a new dual use program, that there was harm done to the medical cannabis program to some degree. And I would like to ask them what they would recommend to minimize the harm to medical cannabis patients. Now that they've been through it, how would they protect the medical cannabis patients so that they would not be harmed by this transition?
Okay, so based on their experience, how do they reduce the harm done to medical cannabis patients?
Yes.
Thank you. Any other members of the task force who are participating by Zoom who have not yet asked a question?
Yes, there's been a lot of talk about the lack of data or the lack of kinds of data. So my question is twofold. One, do we have the data that we need before going into a dual use system? And secondly, I believe last month's meeting presentation by Jillian Shower talked about the lack of national, for states that are in with medical marijuana and dual use marijuana, that there isn't really enough data to look at best practices or best policies. So I would want to know what kind of data is missing.
Okay, do we have the data we need? Is there a lack of appears to be a lack of national data for best practices and procedure? What data do we need to establish best practices and procedures? Thank you. Anyone else, task force members participating by Zoom who have not yet asked a question? Okay.
I have another question.
I'm sorry, who is that?
Oh, Wendy Gibson Viviani.
Please.
For the task force members. It's pretty clear what some of the harmful effects on the patients might be, but I'm not clear on how this might, the adult use legalization might be helpful to patients because of most of the patients' problems currently are because of the Schedule I drug classification and the overregulation. But if adult use might be bringing some potentially helpful effects for the patients, such as like no longer being drug tested at work and losing your job, or did it help open up research? Did it, help open up banking or any of those other things that the Schedule I drug classification cause problems?
So how is the adult use help patients?
Yes.
Okay. All right, I think that does it for our task force members by Zoom who have asked a question. Is there anyone else on the task force who has not asked a question participating by Zoom? Okay.
For my other question from panelists would be around licensing. I know there's a few panelists that dealt with that specifically. but I didn't hear it addressed too much. So it would be when current medical licenses transitioned into the recreational market, what challenges were presented to those licensees, maybe some hurdles. Also, it has been discussed last meeting that some states have mandated that there cannot be any vertical integration of licensees, things of that nature. And looking at our model in Hawaii, where we do have a vertical only, what challenges would be presented if there were any type of mandate on a vertical or a horizontal model in the recreational market?
Okay, so current medical licenses, when they transitioned, what were the hurdles and the challenges? And then the last one was the vertical?
Correct. The vertical and horizontal model, how those challenges play out.
All right. Members of the task force who are in the room, any other questions for the panel? The task force members who are by Zoom, any other questions for the panel?
I have one question. Can they provide data on how the prices of cannabis changed pre and post legalization? So what were the either wholesale or retail prices of cannabis in the medical dispensaries, and then after legalization, kind of through now, how is the both wholesale and retail price of cannabis overall changed?
Got it. Dan, on how prices change pre and post. Okay. Anything else? All right. Thank you very much.
I have one final question, again,
All right.
County of Maui. I would like to hear from those who presented how they're managing the illicit market after legalization.
Okay, how managing the illicit market after legalization.
Correct.
All right, thank you. That wrap it up for questions?
I still have one more quick question.
All right.
Whether or not hemp farmers have been included in the programs in their state.
Whether hemp farmers have been included in the programs in their state.
Yes, thank you.
Madam Chair, I guess this is a good transition time for me to leave. Again, my apologies. I only have to leave because we rescheduled it from last week. And in future meetings, I'm set all afternoon to go as long as we want. Okay, so thank you very much. Madam Chair, I'll turn the meeting back over to you.
Thank you, Judge Bartlett. Okay, so continuing on, the next section is a discussion and formation of the 5 permitted interaction groups. So right now, I would like to call for testimony from individuals who are attending in person. First up, we have May Rimauno Hoy. If you could come forward, please.
Cannot hear. Can't hear it. Can't hear it. Can't hear it.
Can you hear me now?
Okay, now, there we go.
Okay. Okay, great. So, sorry, can I restart my time too? So I'll just start over. So I wanted to thank the task force for allowing testimony for this crucial matter. I also wanted to introduce myself. My name is Mae Fui Maonopo. I'm a family nurse practitioner and founder of the Malia Cannabis Clinic. Since we opened in 2016, we have created access to medical cannabis for over 10,000 patients in our state. I also wanted to say that cannabis was legal in the Kingdom of Hawaii, and it wasn't until 1937 under the direction of Harry Anslinger that cannabis became illegal. And Hawaii actually has the longest relationship with cannabis out of anywhere in the Pacific. I also serve on the board of a nonprofit that focuses on cannabis and equity in medicine. Our nonprofit is called ACAM, which stands for the American for Cannabis and Health and Equity in Medicine. I am testifying on behalf of myself and my patients who can't be here today, and I specifically wanted to talk about agenda item B, social equity. When we talk about equity, I like to use the 4 pillars from ACAM: economic equity, environmental equity, human equity, and social equity. Today, I'll focus on social equity for some of the most marginalized members of our community. When we have a dual use program, we can't leave out people who have been arrested or currently incarcerated or who are on probation, who have been, who are currently experiencing inequity from the failed war of drugs. According to a 2013 report completed by the ACLU, Native Hawaiians and Polynesians are 70% more likely to be arrested for cannabis offenses in Hawaii. So while we sit here at this meeting, some of those people are attending appointments with their probation officers and are being asked to submit a drug screen that tests for cannabis. Why is this important? In 2021, each time, please. Sorry. In 2021, the average length of probation in Kansas was 9.3 months, and in Hawaii, it's 5 years. We have the longest length of probation out of all of the 50 states, and one of the biggest reasons people stay on probation is positive screens for THC. So I just really wanted to request that we look at probation reform when we're talking about social equity. Thank you.
Is there anybody else who's present here today in person that would like to provide testimony? Seeing no one, we will move on to participants by Zoom. First up, we have Greg. You should read, there you go. If you could unmute yourself and introduce yourself, and then please proceed. Greg, are you able to unmute yourself? Okay, great. I'm going to move on to our next testifier, and we'll come back to you. Hopefully, we can get that sorted out. Dr. Clifton Otto.
Thank you, Chair. Just wanted to comment on agenda item 4. I've taken a look at all of the different pre-selected working groups, and it seems to me that every one of them is touched by this elephant in the room, which is the federal conflict that is ongoing. I've outlined how I think this affects every one of these working groups. And so I'm hoping that the task force will consider looking at this issue separately. This is a complex issue that really requires coming up to speed with the latest developments and understanding what actions could be taken before moving ahead with adult use. Because what I see lacking in the other states is anything to protect its end users from the negative consequences that they're suffering because they must violate federal drug law to participate, which is very unusual for a state program. The annual congressional appropriations rider that allows for non-enforcement is not protecting the end user from these negative consequences. So thank you for considering this important issue as a possible separate working group. Aloha.
Thank you, Dr. Otto. Next up, we have Tim Cummings. Please go ahead and unmute yourself. Okay, Tim Cummings, are you able to unmute yourself? Okay, Greg and Tim, I will circle back to you. Next up, we have Margaret Dorsey. Please unmute yourself and.
Aloha task force members, and thank you again for your time. I just wanted to comment on agenda item 4. I want to see, I'm testifying also on behalf of the Hawaii Patients Union. We'd like to see that these working groups benefit patients and caregivers, and we believe it can be done if done correctly. We'd like to see that these working groups aren't just made of task force members and stakeholders, but also patients and those directly affected by the war on drugs and Native Hawaiians. And like we just heard from all of the previous panelists, it seems that when adult legalization happens, patients are really left behind, they're feeling left out, they're feeling like they're not represented at all. And we feel like a great way for patients to be represented, it would be to have seats on these working groups and for them to help everybody involved by representing everybody involved. Yes, that is my testimony right now. Thank you for your time.
Thank you. I'm going to circle back now to Greg. Are you able to unmute yourself? Tim Cummings, I see that you're able to unmute yourself. Please proceed.
I'm just doing this to audit. I'm just for informational purposes.
Okay, so you have no testimony to provide. Is that correct?
That's correct.
Thank you. Okay, Mr. Anthony, James Anthony.
Yes, hello. I have previously submitted written testimony in regards to this item. I would just emphasize that I've been following this meeting for some time now, and I appreciate my 2 minutes here. You know, this characterization of other states as having successfully transitioned, I think your task force has asked many good questions about this. What is the degree of total market capture of the license versus the underground? What has been the impact on the patients? What is the level of decriminalization? Speaking of decriminalization, I may have missed it, but I did not hear a single question on social equity. I'm hoping I missed that because I have been assured in previous meetings by your whatever his title is, the judge, that social equity would be a primary concern of this task force, and yet not a single question. So I'm hoping I missed that. Finally, I would suggest that, you know, one of the impacts on medical is that it becomes subsumed in adult use and it becomes an over-the-counter medication, like aspirin, or if you prefer, like Sudafed, right? I don't know about, you know, different states, you go get a 21, you show your ID and you can buy Sudafed. So that kind of medication.
Okay, thank you. Greg, Going back to you to try to see if you're able to unmute yourself. Okay, so moving on to Elise Pio. Please unmute yourself.
Aloha, thank you for giving me a chance to share. I'm really excited to see that there is a social equity working group. And one thing I just wanted to note is that while we're thinking about how adult use could impact medical patients, the very real fact that medical patient status is a barrier to some of the most impacted communities, to low-income people who may not have health insurance or money to pay for that doctor's visit in order to get that license, that may not have transportation or the ability to take time off of work to get to that doctor's appointment, to be qualified as a medical patient, who may not have money to buy the more expensive strains from the dispensary that they may need. And so just taking all of that into consideration, that people who are medical patients may not currently be classified as that, but that this adult use, I think, is a really helpful step to making marijuana accessible to everyone who needs it and can benefit from it.
It's just flashed on the screen.
Thank you.
Stop the video, but it looked normal to me.
Okay, I don't see Greg anymore. Is there anybody else who's participating by Zoom that wishes to testify? Okay, Kara Wailua. Please proceed. Kara Wailua, please unmute and proceed. Okay, I'm moving on to Hawaii Hemp Company. Please unmute and proceed.
Can you hear me?
Yes.
Perfect. First and foremost, thank you for having this forum to allow us to speak to this. My name is Jediah McRoberts. I am the president of Kauai Hemp Company. We are a vertically integrated hemp farm and CBD producer on the island of Kauai. We are concerned with the inclusion of the Hawaii Cannabis Industry Alliance as a task force member. With the inclusion of a member from HCIA, it seems inevitable that the recommendations made to the task force from this representative will undoubtedly have monetary beneficial implications for the dispensaries that HCIA represents. We believe it is the goal of the task force to provide unbiased suggestions on how to best implement a truly equitable adult use system. We do understand the need to take into consideration how a dual use system will integrate with the current dispensary licensees. However, we are opposed
on the permitted interaction groups. So
Correct.
agenda item number 4.
Correct. This ties into social equity. We are opposed to a task force member having any direct or indirect financial interest in recommendations that will be proposed. Hawaii Chapter 84, subsection 14, conflict of interest states, a task force member shall publicly disclose the nature and extent of any interest or transaction that the task force member believes may be affected by the task force member's official action. We are unaware this disclosure was ever publicly presented in the task force initial meeting. Furthermore, if there are no ethics violations, we do feel the involvement of the HCIA as a task force member will lead to public perception of a biased final report. In light of this, we humbly request that the task force take responsible action to address these concerns. As stated numerous times by multiple speakers in the previous meeting, Hawaii has a unique opportunity to create a dual-use system that is fair and accessible for both operators and patients. Thank you for your time.
Thank you. Is there anyone else on Zoom? Okay, Carol Igua.
Sorry, can you guys hear me now?
Yes, we can.
Okay,
Please.
great. Thank you. So aloha, dual task meeting people. This is a lot of work and there's a lot going on here. I do want to kind of bring to attention the most important thing that you heard from a lot of states talking about the politics of this cannabis program, and that's they left the medical program behind. We've never helped the medical program here. So we established a medical program, but we established dispensaries that can't get affordable medicine to patients. I'd also like to add that although you had a few states on the line, I truly believe—
We are taking testimony on agenda item 4, which is the formation of the 5 permitted interaction groups.
Okay, great. So I would just like to recommend that the state of Maine did make an Office of Marijuana Policy group as they went into 21 and over, and they've done a great job. So I'll leave it at that. Thank you.
Thank you. Is there anyone else on Zoom that would like to provide testimony? Seeing none, is there anyone on telephone that would like to provide testimony? Seeing none. Before we conclude this section, just want to give anybody who's physically in the room another chance to provide any testimony.
Thank you, Chair. I'll be more than glad to head up the tax working group, but I do want some modifications to the mission statement objective as written in the agenda. I would like to first strike the term "the most benefits." I don't think I can come up with the most beneficial type of tax structure. So just benefits to Hawaii, that's fine. Also, I'd like to strike the word appropriate tax rates. I don't know what the word appropriate means, but I will give a summary of tax rates in other states. And finally, after the allocation of monies collected from taxes, that's the purview of the legislature. I just collect money. I think the legislature can allocate monies wherever they want to. Hopefully, they're not thinking of funding this particular initiative with revenues from marijuana, and they will be general funded. But I don't think I'm in the business of allocating money from monies uncollected. Thank you, Chair.
Thank you, Director Choi. So if I got your comments correct, you are volunteering to chair the tax working group, and you have requested that the scope of the tax working group be modified to read to identify and make recommendations on the types of tax structures for medical cannabis and adult use cannabis programs that would provide benefits to Hawaii,
yes,
including identification of tax rates for each
yes,
program, period.
Yes.
Okay.
Thank you, Chair.
And just to also let you know that we have received volunteers or interested volunteers by Garrett Halladire, Ellen Ching, and Randy Gans to participate also on the tax working group. Garrett Halladire, Ellen Ching, and Randy Gans. Thank you very much. Do we have any discussion or questions regarding the tax working group from the task force, other task force members? Seeing none, I'd like to move on to the social equity working group. I have received volunteers to co-chair the social equity working group from Mr. Garrett Halladyer and Mr. Randy Gons. Garrett and Randy, currently the scope of the social equity working group is to identify Hawaii communities and populations disproportionately impacted by cannabis criminalization and make recommendations for social equity and restorative justice policies that would help to reduce and remediate past and ongoing disparities, including equity in the market, community reinvestment, expungement, and resentencing. Do you have any requests to modify the scope of your working group?
Not at this time.
Okay. And just to let you know, we have also received requests from Senator San Buenaventura and Nikos Leverance to participate on the social equity working group. Are there any other task force members that would like to participate on this working group? Thank you. Moving on to the market structure working group. This working group, the person who has volunteered to chair this working group is Mr. Randy Gons from the Hawaii Cannabis Industry Association. And I also have volunteers to participate, Mr. Garrett Halladyer, Ms. Dori Palkovich, and Joanne Takeuchi. As currently reads, the scope for the market structure working group is to identify and make recommendations on the types of licenses that could be allowed, any restrictions on licenses, and home growing. Is there any request by the proposed members of this working group to make modifications to the scope of the working group?
I have a couple of questions in that I don't know exactly how to change it, but the current wording of it seems too narrow. If we're only working on licensing structure, I believe that there are other parts of kind of market structure, even that we heard from the panel today, that should be included. So I don't know how to amend it to make it a little bit broader as far as whether it's the kind of timeline and process, whether it has to do with prices or product types, all of that kind of fits within market structure. And that is not specifically restricted or it's not specifically allowed for in the current language that's restricted to types of licenses.
I can propose as someone who's volunteered to chair to work with the committee to come up with a different scope, be changing the scope, and recommending that to the full committee to take a vote on.
Just a minute.
I have a question.
Thank you. I just needed to get clarification because it was my understanding that the scope must be set at this meeting. And so one of the suggestions that I would have would be to make the wording broader, identify, and so this is a suggestion to identify, make recommendations on the structure of the market, of a potential market for dual use.
How does that work for you, Garrett? That sounds good to me.
That sounds good.
I have a question about this committee. If the marketing structure working group would be the committee to maybe also make suggestions on the composition of the regulatory agency, or if that would belong down in the public health and safety working group. if you're going to determine the market structure, then maybe you could also make comments on what you think the composition of the regulatory structure should be.
I kind of second Wendy's. I think there is a few other issues that aren't really addressed by any of the current working groups. And I'm curious how to address those issues.
I'm sorry, Garrett, I was consulting, so I did not catch your comments.
There's kind of like Wendy is saying, whether it's the agency staffing or regulatory piece to recommend to the legislature, but there's a few other like miscellaneous items that aren't really covered by the current groups, whether that's like advertising or banking or employment issues or exports or geographic indicators. Some of the things that we talked about last week that aren't covered under my market structure or public health and safety, that we might need another group to kind of work on and give them a specific mandate for which items to address.
Understood. So actually, the agenda item 5, which we are deferring because of our time constraints, was intended to address and collect suggestions for additional working groups. And so I would suggest that we defer that discussion and and come back to that discussion at our next meeting.
Thank you.
Do we have any other questions? Okay, moving on. The next group is the medical use working group. And I have volunteers to co-chair that working group with Nikos Leverance and Terry Gorman from Maui County. And then also requested participation by Wendy Gibson, Randy Gantz, Dr. Ireland, who was not able to attend today, and Representative Yamane, who was also not able to attend today. So as written, the current scope of the medical use working group is to identify the concerns and priorities of registered medical use patients and certifying medical providers, and make recommendations on policy that would help to address these concerns and issues. Co-chairs Leverance and Gorman, do you have any comments, any suggested revisions to the scope?
I'm satisfied that the language is sufficiently broad that it includes some of the things that I've been thinking about. Maybe we could, but my baseline is how can we best facilitate safe, reliable, and affordable access to cannabis and cannabis products for medical cannabis patients. So I think that the current language would cover that. So I'm not going to be too much of a stickler over the precise wording of this.
Terry Gorman here. I agree with Nikos. I think it's sufficiently broad for the discussions that we need to have to make sure that our medical patients are cared for properly.
I think so too, but I'm concerned that we're supposed to be identifying concerns and priorities of patients and providers without any of them on the task force. So data collection is tricky because this is confidential information that we're seeking. So I don't know how to include them in this without any good avenues of data gathering. I feel like I have to represent the patients and the medical providers by soliciting their concerns. So how can we include them in this process? Is there some way we can,
So just to clarify, the members of the PICs, permitted interaction groups can talk to members of the public. And the permitted interaction group meetings are not subject to sunshine law requirements. So the discussions that the medical use working group may have with patients and medical certifying medical providers would be considered confidential discussions.
A question for Michelle Nakata. Would it be possible for members of this group to send anonymous surveys to the patient registry?
I can double check with the program if we have the capacity for that. I think a lot of it would just be based on whether we have capacity.
Thank you, Michelle.
Thank you.
I just had a quick point of information for the record. It was stated that there are no patients on the task force. I myself am a patient, so I have to be reflected in the minutes. Registered.
Thank you, Randy. Do we have any other comments, questions regarding the medical use working group? Thank you. So moving on to the final working group, Public Health and Safety Working Group. I will be chairing this working group, and I have volunteers for participation: Senator Sam Buenaventura, Mr. Barrett Otani, Randy Gantz, Jared Radula, and again, Dr. Ireland, who's not able to attend today. Currently, the scope of this working group is to identify and make recommendations on policies to safeguard the public and consumer health and safety, including preventing youth access, impaired driving, use disorder, cannabis use disorder, and mental health impacts. Do I have any suggestions or modification of the scope of the working group?
Just the sentence, the way that it reads, it says preventing youth access, impaired driving, use disorder, and mental health. So is it preventing mental health? I mean, it's kind of, or impaired mental health, or just the part of, it's just, I'm not sure what and mental health means, but preventing access, impaired driving, and mental health.
Impacts to, how about impacts?
How about, yeah. That would make sense. Thanks.
Okay. Any other comments or questions? Okay. So the last thing that we need to do with regards to the permitted interaction groups today is we do need to identify a report out date. My suggestion, and I'm hoping that this will afford the groups enough time to report out, would be to receive reports at the July meeting, if that's reasonable. Troy, is that okay with you? Okay. Garrett and Randy for the social equity group.
If reports are due in July, what would be the timeline moving forward from there? Like consolidating those reports and getting them together and drafted for the legislature. The only reason I ask is because some of these are pretty robust discussions, such as market structure, social equity, and there's some ongoing discussions in the cannabis industries around the nation happening currently. That maybe a little bit more time would be beneficial. So possibly August would be something I could recommend if that lines up with our timeline to be able to give legislature something robust.
Okay, so just to let you know, so the report out date would be basically for the permitted interaction groups to just report on the findings of their work group. The task force cannot discuss or take any actions on that reported information at that particular meeting. We would have to wait until the next meeting in order to discuss and take action on it. So it will push it back, a month. We are required to submit our final report to the legislature essentially by the beginning of December. So we need to make sure that we have adequate time for the overarching report of the task force to be compiled, reviewed, approved by the task force in time for it to be submitted.
That makes sense. I think having that time frame between the report and when we can then discuss and people will give us enough time to hear the report and then come together with our thoughts and then discuss it the next one.
Okay, so July.
Michelle, after, so on the one, like in July, when we present the reports, as we wait a month, is there allowed to be like additions or refinement of the report during that month, or is it stuck where it's at?
So, but then, so we should move it back to August.
Yeah.
Okay. Sorry, getting further clarification. Once the report out is completed, the pig is dissolved.
Okay,
So
got it.
That being said, it may be worthwhile instead of doing the report out in July, doing it in August, because that will actually give you time to compile a draft report of the recommendations from the working group.
Thank you.
Does that work better?
It does. Can we possibly put on an agenda item that in July, maybe we not have a report out, but maybe an update on what those pigs are up to, and maybe just everyone kind of what we've been doing and where we're at? Or is that it's not permitted?
Hold on. Okay, sorry. As you can tell, I'm not well versed in sunshine law requirements, and that would not be permitted. Thank you. So August, we're talking about August. Market structure working group. Would an August deadline be acceptable? That's back to you again,
Yes.
Andy.
Sure.
Okay. Medical use working group. Nichols and Terry is August deadline, okay?
August works for me, thank you.
Agreed, thanks.
Okay, thank you. And public health and safety working group, I would say August works for me. So is any other members of the public health and safety working group okay with that? All righty. Okay, I think we are done for today. Oh, please go ahead.
I noticed in our material, we don't have each other's email address. Would you be providing that so I can at least contact my people in the working group?
Yes.
Okay.
Who else?
And also, if the public would like to opine on the tax working group, can my email be made public so they could just send me their comments directly during this time, so I can at least hear what they have to say. So would you be public? Do we have a website or something for our task force here?
There's a dual use task force website webpage on the Department of Health Office of Medical Cannabis Control and Regulation.
Okay, great. So if you could just put my email up there, and anybody want to talk about taxes, I love talking about taxes. So we can talk about taxes. The other thing is these meetings, I can't just let it go on forever. Is there a possibility that we can have a start and stop time for our meetings? I can't block off a whole afternoon for these meetings. Can we just set it to a time certain?
The limitation is that we are required to allow for public testimony, and we cannot. And I think that's the unknown, is because we don't know how many individuals, may show up to.
Also, I'm trying to follow along with the written testimony versus the oral testimony. Could we have a schedule of people that are going to testify in person versus just written, so we can kind of follow along with the written testimony?
Okay, we can try to do that. I think it's the problem is that we don't generally have people sign up in advance, and we can't make that a requirement. And so we are having people message in as the meeting is being held to say
Well,
that they would like to.
whatever moves this process along. And finally, the agenda item that we skipped today, I think was on the last agenda item, and I think that was skipped the last time. So if you could have agenda item number 5 on the top of the agenda on our next meeting, I think people really want to talk about number 5.
Very good, well done.
Okay, thank you, Chair.
Do you have any other comments or questions? Ms. Palkovich, please.
I have a question on the process. So when the pigs present their report in August, then on the next meeting, there'll be discussion on those reports.
Ellen,
So
I'm
at
sorry, can you speak up a little louder?
Yes, when the pigs, can you hear me? Can you hear me now?
It's still very soft, sorry. Maybe it's just my hearing.
No, yeah, just turn on the volume of the speakers.
I'm just gonna turn them. Is that better? Is that better?
It's a little better.
Okay, so my question is on when the pigs report in August, and then on the next meeting, there's discussion on the reports. Is it on the next meeting that any amendments, or at that next meeting, does the task force need to accept those reports? What is the process?
So it would be at that next meeting that the task force would discuss the reports and take any necessary actions.
Which could be amending or accepting or even rejecting.
Correct.
Got it.
Yes, just quickly, is it reasonable to assume that the chair of the working group will contact the members?
Yes.
They will contact us.
Yes, I will leave it to them.
Thank you.
Okay. Seeing no further raised hands or questions, our next meeting is scheduled for June 27th, same time. And same place. Meeting is adjourned. Thank you. Good job. No whining and no feedback.
Yes, I found the right frequency, no interference anymore.
Thank you so much.
Now you can breathe. Thank you, Michelle.
Thanks, Michelle.
Thank you, Michelle. Appreciate you.